So we've made this video to explain what the PACT form is, what it does, and to demonstrate how to talk to patients and family members about it. PACT stands for Planning Ahead for Care and Treatment. The PACT form was created about a year ago by hospital consultants and GPs in Milton, Keynes, in a response to an observation that some patients were perhaps being admitted to hospital when they or their family felt that they would be better cared for at home. It felt like people perhaps came to hospital because they didn't feel they had any other choice. Sometimes the expectations from patients and loved ones really didn't match what a hospital admission could achieve. For most life-limiting illnesses, and certainly as dying becomes closer, there are a series of possible and predictable events that may happen. What the PACT form is about talking through these scenarios with patients who have capacity and documenting their wishes, i.e. planning ahead for care and treatment. The PACT form can also be used for patients without capacity, and in fact was designed initially for this purpose. The conversation then being had with those that know the patient best to try and ascertain what the patient would want if they could make decisions for themselves. The form, once completed, stays with the patient. It should be documented in the hospital and community notes that such discussions have taken place and a form has been completed. The form is then easily accessible to be referred to by patients and their families, but also by clinicians such as ambulance staff and out-of-hours GPs if needed. The PACT form is to be used in conjunction with other advanced care planning documentation and DNA CPR forms. It's similar to other initiatives across the country, such as the Respect form, but is perhaps more useful because it documents a specific plan for a specific situation. The PACT form can be found on the hospital intranet or at GP practices. We'll now demonstrate an example of a PACT conversation and documentation with a patient with capacity.
Hi Sheila.
Dr. Whale.
It's good to see you again.
Nice to see you too.
Mr. Smith, I'm Dr. Whale. I'm one of the consultants in the hospital. I said I'd come back, Sheila, and just pick up from where we left off before.
Okay.
See what else you wanted to talk about. You said you were going to talk to your husband about a few things before we met up.
Yeah, I'm really sorry. I think when you caught me on Monday, the pain was really bad.
Bad day, weren't you?
Yeah, but the medicines that have been prescribed now have worked and I'm much better, thank you.
Yeah.
But to be totally honest with you, I'm just sick and tired of coming back and forth to the hospital, and as I said to you the other day, I'm not getting any better, and I feel like we're just wasting our time coming back and forth. And we could be spending time together, couldn't we?
Yeah. I'm actually feeling a bit better and the pain's better than it was. I was really keen to come back and pick up that conversation too, the one about doing things differently. Yeah. Okay. I wonder whether there's a few things we could plan ahead for and come up with a plan and write down a plan.
Okay.
And the reason I'm asking you to try and think about that now is that I know from experience that it gets harder to make decisions as people get sicker and harder to tell those around them what's important to them. And as your doctor, I need to know what's important to you, so we can both work towards that. Okay. And I think by doing this, it'll give you some sort of sense of control over things.
Yeah, that sounds good. John and I have spoken about this, haven't we, John?
We have,
and we think that we should just focus on making most of the time that we've got left. Yeah.
Okay.
That sounds good.
Making the most of the time you've got left. Okay. Tell me more about that, Sheila.
Well, as you know, the cancer spread to my lungs and my liver. And I know I can't be fixed. But if I can't be fixed, I don't see the point of keep coming back and forth to the hospital, to be honest with you. But the trouble is when the pain's bad and the vomiting starts, then I panic and we call the ambulance. And the ambulance crews so nice, aren't they, John? But I just don't feel that, I don't even think they feel that I need to go back into the hospital, but I don't know what to do when that happens.
Okay. As we talked about the other day, Sheila, that the tummy pain and the vomiting is because your bowel's becoming blocked. Okay. And I guess that could happen again. Okay. but in my experience, it often settles with that pump we started.
Oh, okay.
Okay.
That's good, yeah.
So maybe the first thing to do, if that happens again, is to call out the hospice nurses and ask for that pump to be put back up again.
Okay.
And if that didn't work, then the next step would be to come into hospital, maybe just to A&E, to have a tube put up your nose and down into your tummy to take away the fluid and the pressure and the pain and the sickness. Okay.
That drainage thing you talked about.
The drain thing, the nasogastric tube.
Yeah.
Okay, and then you could go home with that. You could go home with the tube.
I can go home with the tube and then I don't have to be admitted.
No.
Oh, that sounds
That's
good.
good.
I'd like to stay at home.
Why don't we write that down on a plan? Okay.
That's what we need, isn't it?
It's a good start.
Yeah.
So this form, it's called Planning Ahead for Care and Treatment, PACT form,
Okay.
allows us to think about different problems that might happen, write them down and write down a plan for people who might not know you so well as your usual doctors and nurses. It gives them some idea if they're called out in the middle of the night or if the ambulance crew's called.
Okay.
They've got some sort of plan to follow
Okay.
that might mean that you don't end up back in hospital.
So that stays at home with me.
So that stays with you.
Okay.
That's good. That's what we need.
Yeah.
Yeah. And it's not about not coming back to hospital, but that's
No.
what's needed. It's about doing the right thing at the right time. For
Okay.
you, Sheila.
Okay.
Okay, so I'm going to write down this one about bowel obstruction. Are there any other problems that you might foresee that might happen to you?
I don't know. What do you think?
So I guess one thing that might happen is that you might become jaundice, you might become yellow.
Yeah, it started, isn't it?
Yeah.
Yeah.
Big.
That's okay.
And sometimes that's because the liver's not working because of the cancer, or sometimes the cancer blocking the liver tubes.
Okay.
For some people, they come back into hospital for more tests. And sometimes we find that it's because the tubes are blocked and we can put a stent in to relieve that pressure and to try and help the liver work again.
Okay.
That takes about a week in hospital.
Oh, I don't want to spend another week in hospital.
No.
No. We do, like I said the other day, we don't have much time we've got left, so I really don't want to spend a week in hospital.
Okay, so the thing to do with jaundice and it becoming yellow is just to ignore it then, okay?
Okay.
Just let it be
Okay.
and not have any more tests for it.
Yes.
So I'm going to write that on the form too.
Thank you.
I guess another problem that could happen is that you could develop an infection. Yeah.
Yeah.
So in my experience, people who become more unwell and spending more time in bed often develop things like chest infections.
Okay.
Okay. And I guess the treatment of chest infections can be different at home to in hospital. So in hospital, we can give you much stronger antibiotics through your veins, whereas at home, we can only give you tablets or medicines by mouth. I don't know whether you've got any thoughts about what you would want if we developed a chest infection or another type of infection.
I just want to be at home, Dr. Well. I just want to be in my own bed. I don't want to come into hospital. I can have my infection treated at home if I have to be treated.
It's really sensible, Sheila. Okay, I think if you developed a chest infection or another infection, it would be sensible to try some antibiotics by mouth,
Okay.
but perhaps acknowledging that if they didn't work, it's more important for you to be at home.
Okay. Yeah. Yeah. That's all right, isn't it, John?
Yeah.
Yeah. Yeah.
Let's add that to this list then. So if you've got an infection, you
Okay.
try oral antibiotics.
Okay.
The priority would be to stay at home.
Yeah.
Yeah. Another thing that happens, Sheila, as people get sicker, is that they don't want to eat and drink in the same way. because they don't need to, because they're not spending energy in the same way. And I wonder if that will happen to you too. And I wonder if when that happens to you, that actually the right thing to do would be to stay at home and not to come into hospital for a drip.
I just don't want to come into hospital. It's all really.
So let's write that one down too.
Okay.
When you feel like you don't want to eat and drink in the same way, that you prefer to stay at home and be supported at home.
Yeah.
We've talked about if your bowel becomes obstructed. We've talked about if you become yellow. We've talked about if you get an infection.
Okay.
We've talked about when you don't feel like eating and drinking.
Okay.
Yeah. There was one other thing I wanted to talk through, if we can.
Okay.
And that's about how you'd like the very last bit of your life to be. The bit when you start to die, Sheila. Is that okay to talk through now?
Well, I want to be at home, but I'm worried about John and the family because ideally I'd like to die at home, but I worry about that, how that will be and whether they'll have support. I don't want to be a burden.
I want what you want.
Yeah, but I don't want you to have to lift me and wash me. I don't want to be a burden.
We can do
And
that.
it might get too difficult for you anyway, so
But we can do that, can't we? If she wants to die at home, we can have that option, can't we?
We've got a team based over at the hospice whose role it is to do that, to coordinate the carers in the house and to try and ensure that people die at home if that's what they
So he
want.
wouldn't be on his own?
So we would provide carers to come and help and to support.
Good.
It's comforting to know.
Yeah.
I just wouldn't want you to be on
And
your
if
own.
things got too hard, especially with the kids at home, then we could think again. Okay.
Maybe the hospice?
Maybe the hospice. Yeah.
Okay.
So shall we write that down, that
Yes, please.
when you start to die that you'd want to stay at home or go to the hospice?
Yes, please.
Yeah. How are you feeling about things now?
I'm okay, but and it's helpful to talk about these things, and I do feel like we've got some choices now, haven't we, John?
Yeah, options now.
Yeah, but I'm just still a bit concerned though what dying's like, because I'm just a bit worried that the pain will get worse, and what impact that will have on the family if they see me in that much pain. So I'm worried about that because it has been very painful until we change the meds this week.
Okay. So questions about pain and about dying?
Yeah, I don't really know what to expect.
Would you like to talk that through?
Yes, please.
Yeah, good to talk to me.
Yeah, sorry for you, John.
Yes, yeah, it's fine.
Okay, so I don't know that your pain's going to get any worse, Sheila.
Okay.
And I know we've got lots of good painkillers to manage pain.
Yeah. I do feel much better now with the new meds.
Yeah, you do that.
Yeah, much better.
Yeah.
The sickness is better as well.
So I don't know that will change.
Okay.
Okay. In my experience, dying's usually a really gentle, peaceful thing.
Oh,
Okay.
really?
Really.
Okay.
So what happens is that people, as they get sicker, they kind of withdraw from the world a bit. So they become less interested in the things around them.
Yeah.
More tired perhaps. But when they wake up, often they're still them. But that time gets shorter and shorter, and they spend more and more time asleep. Okay.
That's happening now. I'm getting more sleepy now, aren't I?
Maybe.
Yeah.
Maybe. That phase is different lengths of time for different people.
Okay.
Okay. And then the next phase is they simply don't wake up. Okay. They become more and more unconscious.
Okay.
And at some point their breathing changes. Okay.
So I wouldn't be necessarily in a lot of pain then?
No, I don't think so.
Good, that's good.
And as their breathing changes, it changes in rhythm and changes in depth. And that's a sign that death is really close.
Right.
Okay? And then people take a last breath out and the next breath simply doesn't come in again. Okay. It can be as simple and as gentle as that.
Okay.
Okay.
It's helpful to talk about it, thank you.
It is.
Yeah, thank you. It's just scary.
Yeah, it is. Yeah.
Yeah, but maybe by knowing what to expect.
Yeah.
And being supported and your family being supported,
Okay.
it'll be a little less scary.
Yeah.
And maybe if we've got a good plan that gives you some control over things.
And this plan, who sees this plan?
So this plan stays with you.
I'll have it at home.
You have it at home.
Okay.
And you show it to any healthcare professional that comes in the door. Okay. And I'll make sure your GP knows you've got a plan and what's in the plan.
Okay.
Okay.
And can we change our mind about the plan?
Of course you can.
So it's not fixed.
It's not fixed.
Okay. That's
It's
it.
merely a guide
Okay.
if you can't tell us what you want at the
Okay.
time. Okay.
Okay.
It tells others what was important when we had this conversation.
Okay, that's good.
Okay, so it's not about not coming back into hospital, it really isn't. It's about doing the right thing at the right time for you.
Okay. In case I can't speak up.
In case you can't speak up.
That's really good, thank you.
That's good. You're welcome. So I'm going to finish filling in this form.
Okay.
I'm going to write your contact details on it. If that's
It's
all right,
fine,
John,
yeah,
for someone to be
yeah,
contacted. And I'll make sure the form goes home with you.
Sure.
Okay.
Yes.
Any other questions, Sheila?
Oh. Again, it's just because I'm worried about John. But no, I think I'm all right, actually. Yeah, I think, this will really help. This will help you, won't it?
Yeah, it will do.
Okay.
Any questions, John?
No, thank you. It's been really helpful having this talk.
Thank you.
Okay.